Um, so we're very fortunate to have Dr. Suresh Vedantham from the Mallinckrodt Institute here to tell us a little bit about management of venous thromboembolism. Dr. Vedantham is the principal investigator for the ATTRACT trial, and I'm sure he'll tell us a little bit about the trial and some management of VTE. Just to give you guys a little information about Dr. Vedantham, he did his residency training at UCLA and his fellowship at Stanford. He has multiple publications in the management of DVT and VTE, and we're very fortunate to have him here tonight. So thank you for coming.
Well, thank you so much. That's a very kind introduction, and I'm really looking forward to speaking with you all, and hopefully also at the end of the talk having some time to handle some questions so that we can make the best use of this terrific format. So I've been dealing with, I've really subspecialized in the area of the care of patients with venous disease for quite a while now. I've been on the faculty at Mallinckrodt for about 15 years. And that's taken us in all kinds of different directions where I never expected to be, actually, so far down my career. So today's talk is entitled Interventional Therapy for DVT, a New Opportunity for a New Era. And just some quick disclosures. The ATTRACT trial is funded by the NIH. I lead the administrative core of our Translational Research Center here at Washington University in thrombosis, and that's also NIH funded, but I don't speak for them. We also receive supplemental support for the ATTRACT study from several companies that you see listed here: Bayer, BSN Medical, Covidien, and Genentech. And then the use of thrombolytic drugs for DVT is off-label. The use of stents for vein indications is largely off-label. So as you all know, deep vein thrombosis causes a number of manifestations, and in particular severe leg pain and swelling. Patients are typically treated with anticoagulant drugs, commonly heparin followed by ultimately warfarin, although that is changing currently. But the bottom line is that is really done to prevent pulmonary embolism, and it's done to prevent thrombus extension, and really anticoagulants are very effective in that particular respect. However, anticoagulants don't directly dissolve the thrombus, and a patient's symptom improvement on anticoagulation varies tremendously from person to person. With some people, they improve quite rapidly and quite completely. Many patients have their improvement take several weeks to months, and fully 1/3 of patients who develop a lower extremity DVT never return to their baseline symptom level and to their baseline quality of life. And obviously that is a very significant problem given how common DVT is. And just to give you some perspective, there are about 250,000 first episodes of DVT in the United States per year, and total of around 600,000 cases of DVT all-comers per year. And as again, you can see that from the middle image here that there's thrombus filling this vein, this femoral vein on this venogram, causing congestion and inflammation, and that inflammatory response turns out to be very important going forward. This picture on the left is what I call my Your Vein on Drugs image. This is the patient who was treated by what would be considered correct, good, standard treatment for DVT, and is being evaluated 1 year later when he's very symptomatic in his leg. And as you can see here from this venogram, the common femoral vein that I'm pointing at here is septated and channeled. There are large filling defects that I'm pointing out here, and lots of collateral veins. This is a very poorly functioning vein, and that really reflects the fact that essentially the anticoagulants haven't really dissolved the clot per se. They've just prevented it from embolizing. And in the long run, the inflammatory response to thrombosis causes permanent damage to the one-way venous valves inside the vein, and that's what we call, that causes valvular reflux or backwards flow in the vein when a patient is upright. And the combination of valvular reflux and the residual thrombus that that causes obstruction of the vein leads to a phenomenon we call ambulatory venous hypertension, which is a fancy way really of saying that the pressures in your vein are significantly elevated when you're upright and walking. And the degree of ambulatory venous hypertension has been shown to parallel the clinical manifestations of something that we call post-thrombotic syndrome, or PTS. Now, when we talk about the post-thrombotic syndrome, you'll hear a lot about it, and people like me that give talks on DVT usually will draw upon the most dramatic pictorial representation that we can find, like the one that you see here on the left, this nasty-looking venous ulcer. And it's certainly true that post-thrombotic syndrome causes ulcers. But I think that we have to remember that more commonly, the typical manifestations of post-thrombotic syndrome are daily aching, swelling, fatigue, heaviness of the affected limb that occurs on a daily basis over the long run. A minority of patients will develop skin changes. Maybe about a third to a half of people who develop post-thrombotic syndrome will get significant changes in the skin of their legs, typically hyperpigmentation, subcutaneous fibrosis, and a minority will develop venous ulceration. So overall, of all DVT patients, probably around 5% maybe will ultimately develop an ulcer. The post-thrombotic syndrome is very common in people with the DVT. Once it is developed, it's really considered a lifelong condition. So it's not something that has any sort of evidence-based, proven, consistently effective treatments. And once it's there, it significantly impairs a patient's quality of life. And prospective studies have shown that the post-thrombotic syndrome is, in fact, the leading determinant of a patient's quality of life 2 years after their DVT. And, in fact, that the severity of their post-thrombotic syndrome predicts just how bad their quality of life will be. Venous ulcers, once they develop, often recur and are very difficult and expensive to treat, as you can imagine. So how common does this actually occur? Did someone have a question? No. Okay. So how common does this actually occur? Well, if you look at prospective studies done in kind of the modern era where we have validated measures of the post-thrombotic syndrome, et cetera, and I won't go into all the detail on all these studies, of course, what we can conclude is that if you take patients with a proximal DVT, defined as a DVT involving the popliteal vein or above, maybe about half of them will develop post-thrombotic syndrome. If you count only patients with thrombus in the common femoral vein and or the iliac vein, you're talking about 60%. So that's a lot of people that are ultimately developing this long-term problem that's largely gone unaddressed over the years. And so people have proposed, therefore, well, if it's the clot that's causing the problem, then why not remove the clot up front? And could it be that by getting the clot out of there, we'll preserve the venous valves, eliminate the patient's symptoms up front, keep the vein open, and prevent the post-thrombotic syndrome in the long run? And there's a lot of evidence that suggests that the status of a vein with respect to how much clot is in it in the long run is predictive of the ultimate outcome. There were ultrasound studies done in the 1990s that demonstrate that if you look at a patient with a DVT every week with ultrasound, the vein segments in which the clot spontaneously goes away are those in which the venous valves tend to be preserved, whereas the vein segments with residual clot tend to have valves that are not working. We know that recurrent DVT in the same leg markedly increases the risk for the post-thrombotic syndrome. It probably takes the risk and multiplies it by 3 to 6 times in an individual patient. We know that after a patient has received a full course of anticoagulant therapy, if you ultrasound them and take a look at how much residual clot is left, the amount of residual clot left predicts the risk of recurrent clotting episodes in the future. So the more clot you have left, the more likely you are to develop recurrent VTE. And then finally, a non-therapeutic INR in patients who are on warfarin therapy has been shown to increase the risk for the post-thrombotic syndrome, presumably via more clotting that occurs. Now, since the early 1990s, interventional radiologists pioneered a procedure called catheter-directed thrombolysis. And with this technique, basically, you can take a look at this venogram in a patient with a iliofemoral DVT. The left image shows the popliteal vein and a venogram showing thrombus or filling defects filling that popliteal vein. The middle image is the femoral vein, and the right image is the iliac vein full of thrombus. we've accessed the popliteal vein under ultrasound guidance. We've advanced the catheter into the venous system and injected contrast to do the venogram, and then we've placed in there a multi-site hole catheter, which is, for those of you who have not seen it, something akin to a garden hose, miniaturized though, with side holes that are then embedded directly into the clot. Through that, we've infused a solution of a thrombolytic drug, and I think in this case it was TPA, which again is off-label, but which has been used in practice for this purpose for nearly 20 years, and the dose we gave is a 0.5 to 1 milligram an hour, so a very low dose relative to what's used for example, treatment of stroke or myocardial infarction or whatever with TPA. And then you can find here, after overnight thrombolysis, the vein looks largely open here, with patency of the popliteal vein here, femoral vein, and the iliac vein. This is a prone patient, since we accessed the popliteal vein. As you can see, the iliac vein is patent, but there's a stenosis at the very top of that vein, and that reflects something that we call May-Thurner syndrome or iliac vein compression syndrome, where patients develop webbing and stenosis of the common iliac vein, of the left common iliac vein due to the crossing right common iliac artery. And then we went ahead and placed a stent in there, and this is a widely patent vein on the right here, and this patient was doing great a couple of years into follow-up. And really, we've been doing these procedures for almost 20 years now, and we know that if we get a patient who has relatively recent symptom onset, meaning in the last 2 to 3 weeks, we can get the clot out and get the vein open almost all the time. However, what we also know is that we have to give them a thrombolytic drug to do it in general, and that confers an additional risk of bleeding complications. And I would say that, based on what we know now, somewhere between 3 and 5% of patients are going to develop what's called a major bleed, i.e. bleeding enough to require a blood transfusion or 2 units, or I should say a blood transfusion or worse, and maybe half of 1%, really rare, will develop an intracranial bleed or a life-threatening bleeding complication. But if you really put this into perspective, remember that, in interventional radiology, almost every single thing we do has come from taking a surgical procedure and attempting to improve the safety and patient friendliness of that procedure by doing it in a less invasive way. DVT is exactly the opposite. It's one of the very few things that we do where we are actually taking a treatment that was very safe. And anticoagulant therapy, if you put a patient on low molecular weight heparin and then Coumadin, the initial course of anticoagulation, if you take all comers, maybe confers a 1 to 1.5 risk of a major bleed, and then you might get 1% per year for subsequent Coumadin therapy. So very, very low rates of bleeding, really. If you take into account people who would be eligible for thrombolysis, which is really people that don't have significant bleeding issues or risk factors, if you just put them on anticoagulation, almost none of those patients would bleed. So when you talk about 3 to 5%, that is a significant increase in risk. And as a result, despite the fact that we've been at this for about 20 years and have shown that we can open these veins pretty reliably for a long time, this form of therapy has really never gained traction as a way to treat the general population of patients with the DVT, and there's been tremendous controversy about this. If you take a look at the top 4 papers that I've listed here, these all represent organizations that have published practice standards that suggest that catheter-directed thrombolysis is often a reasonable thing to do for patients with an acute iliofemoral DVT, meaning DVT in the common femoral vein and or iliac vein. But you'll notice that those organizations, which are the Society of Interventional Radiology, the American Heart Association, Society of Vascular Surgery, and the American Venous Forum, are largely composed of physicians that do the procedures and bill the procedures, and which is not really surprising. They'd be more tolerant on their use. If you take a look at the American College of Chest Guidelines, current guidelines, you find that they discourage the use of catheter-directed thrombolysis. And again, those guidelines are a bit more rigorous in the sense of the details of how they do their evidence review. They rely almost exclusively on large randomized trials, of which there's almost nothing in this particular area. And they're developed primarily by medical thrombosis subspecialists who tend to be very strongly evidence-oriented, and their general perspective is that of medical physicians who really view any type of procedure or invasive procedure as a scary thing. So there's been tremendous controversy on this point for a number of years. Just this last year in 2012, we finally got the first bit of actually good data looking at the use of catheter-directed thrombolysis. And this was a Norwegian randomized trial called the COVENT study, where around 200 patients were randomized with a proximal DVT, and about half received anticoagulation alone and half received anticoagulation plus catheter-directed thrombolysis, and patients were followed for 2 years. And as you can see from the middle row here, indeed, the use of catheter-directed thrombolysis reduced the risk of the post-thrombotic syndrome by about 26%, from 56% to 41%, with a statistically significant p-value here. There were a few major bleeds, and again, there were 90 patients lysed in this study for which outcomes were reported, and 3 of them had major bleeding complications, of which 1 required a blood transfusion and 1 required surgery. There were no intracranial bleeds, and the authors concluded that the bleeding complications ultimately didn't affect the patient's long-term outcome. On the other hand, 3% is 3%, and again, we're basing this on just 90 patients, and you can imagine there's tremendous statistical uncertainty on any estimate of bleeding complications based on just 90 patients. In addition, this study was, again, it was performed in 4 centers in southern Norway. They used the type of lytic therapy that we might have given here in the U.S. in the late 1990s, basically a drug infusion where you just park a catheter in the vein and infuse the thrombolytic drug and reposition the catheter in the thrombus as it dissolves. Nowadays in the United States, we're much more inclined to use devices to also chew up, aspirate, macerate the clot to speed thrombolytic therapy, reduce the needed drug dose. And we also use stents quite a bit more than they used in the Norwegian study. And so it's hard to know if that study really can be applicable or reflects what would be occurring in United States practice with the use of these procedures. So if you were to say to me in the year 2013, should I or shouldn't I use catheter-directed thrombolysis for DVT? Well, what I would say is you got to consider a number of important factors. First of all, clinical severity. Remember, there are different scenarios that patients present in. One of them is the rare patient that has acute limb threat. In other words, they've got such bad DVT that they've plugged up even their venules to where you get limited arterial inflow as well. Those patients obviously absolutely have to have something invasive done, whether it's surgical thrombectomy or catheter-directed thrombolysis. There's really no doubt about that. But that's obviously a rare situation. Almost always those are cancer patients. Now, the other situations are patients who have come in with the DVT and then get put on anticoagulation, and then at some point, 5 days, 5 weeks, whatever, after that point, their leg just doesn't get better or it gets worse. And in that situation, that's probably the most common situation in which we get called nowadays in clinical practice. So that's what I would call almost second line or salvage catheter-directed thrombolysis. The third situation is just someone comes into the ER with their DVT, you diagnose them, you put them on anticoagulation, and you go lyse them to prevent the post-thrombotic syndrome. That, as you can imagine, you're not really selecting patients for that. You're saying almost anybody with a DVT, unless they've got some major contraindication to thrombolytics, you're going to go ahead and lyse. And you can imagine then you're going to apply that factor of 3% bleeding complications and 0.5% intracranials to a huge denominator of patients, right? Over probably 100,000 patients per year. So you're going to get a fair number of complications. And as a result, the standard of evidence we need to meet to prove that we're really benefiting most of the patients, I think has to be fairly high to be recommending it for widespread use in just anybody that walks in with their DVT. I think other things to consider that are very important, anatomic severity, and in particular, are the common femoral vein and or iliac vein involved with the DVT. Remember that the main, if you have your femoral or popliteal vein occluded, the main collateral drainage of that limb is the profunda, or the deep femoral vein. Well, if you're also occluded above the entry point of the deep femoral vein, which occurs in the groin, then you're going to find that you have much more significant swelling and pain in your leg. And it turns out from prospective studies that those patients are about 2.5 times more likely to develop recurrent DVT in the future, and they're 2 to 3 times more likely to develop the post-thrombotic syndrome. So this is a very important point, because even for people, for your colleagues that aren't going to be interventional radiologists, it's important for them to know that when they diagnose a DVT in their ultrasound lab that involves the common femoral vein, that's a high-risk condition. That patient is at significant risk of developing post-thrombotic syndrome and recurrent DVT in the future. Other factors to consider: risk of complications. Obviously, anybody with an intracranial lesion, an intraspinal lesion, very recent surgery or obstetrical delivery, these are patients, or severe thrombocytopenia. These are people that really cannot be lysed with thrombolytic therapy safely. People who have severe pulmonary embolism, or who are just otherwise very sick to where you can't put them on your procedure table prone and sedate them for a procedure, those are also not patients that you would consider for this form of therapy. And then finally, I think that it's important to realize that we're currently in a situation where we can't necessarily tell a patient confidently that we know for sure that lysing them is going to benefit them in the long run. And therefore, it's very appropriate to explain and give them a balanced sense of the risks and benefits so that they can make their own choice as to whether they would prefer a more invasive approach versus conservative therapy. Now, that said, over the last several years, we've had continued innovation in the way these procedures are performed, and I don't think that any of us who are offering a high-risk procedure to our patients should be satisfied with the current state of evidence, which really has a lot of uncertainty associated with it. So some of these devices you see pictured here, on the left you see something called the trellis device, which is a thrombolytic drug delivery device, essentially, that enables one to deliver a bolus dose of the thrombolytic drug to a targeted, isolated segment of the clot. So what you do is you put the device in, you inflate these two balloons that you see here around the clot, you inject the thrombolytic drug into one of the syringes, and it comes out side holes inside the clot, and then you press the button here that turns on this dispersion wire that basically spins inside the vein to get rapid dispersion of the thrombolytic drug within the clot. And the idea is that by doing that, you can get much faster clot removal and by getting faster dispersion. Other devices are similar, have a similar concept. The angiojet device you see on the right here enables you to basically pulse spray thrombolytic drug-containing fluid into the clot, getting faster dispersion. And then on the left here, this is kind of another accompanying image, I guess, of the ECOS catheter, which is basically a multi-site hole catheter that also emits low-power ultrasound waves that loosen fibrin strands and enable faster dispersion of the thrombolytic drug within clot. And again, none of these methods have been tested in prospective trials to where we really know that they improve the post-thrombotic syndrome. However, for a couple of these techniques, the trellis and the angiojet here, we do know that in many patients, what used to take us 30 hours to do in terms of opening up a vein, we can often get single-session clot removal, like in the patient you see here who had thrombus filling the femoral vein and iliac vein here, in whom we went ahead and lysed the patient and opened up that vein very quickly in about a 2-hour period. So we know that we can do something with these devices. Now, again, a lot more evidence is needed to show that really we're improving health outcomes in these patients in the long run. So the ATTRACT study really was a study that came together in an effort to address this big controversy that's been out there as to whether or not we should be routinely lysing people with DVT. I think it's worth your noting that the Society of Interventional Radiology's Research Foundation, the SIR Foundation, provided initial support to the development of the consensus panel that ultimately resulted in the development of this study, so that's an important thing to know. But the bottom line is that this is a NIH-sponsored, multi-center, randomized clinical trial. That's we're going to basically enroll 692 patients with proximal DVT to receive or not receive pharmacomechanical catheter-directed thrombolysis along with anticoagulation and compression stockings. versus the control arm that'll just get anticoagulation and compression stockings. And the patients get randomized up front. They all get treated with anticoagulation, and they get followed for a 2-year period afterwards. They get followed pretty much in just the same way, patients in both treatment arms. They get evaluated by assessors that are blinded, and they complete questionnaires themselves. And there are 6 follow-up visits between 10 days, 30 days, and then every 6 months for 2 years. The primary outcome measure is something called the Villalta scale that measures post-thrombotic syndrome, and obviously you don't care too much about all the details, but the bottom line is that it involves the patient scoring 5 common symptoms of the post-thrombotic syndrome that you see listed here, and a blinded clinician assessor that doesn't know whether they got lysed or not, evaluating their lower extremity for edema, induration, hyperpigmentation, venous ectasia, redness, and pain during calf compression. And then you basically calculate a total score, and post-thrombotic syndrome was a score of 5 or above, or the presence of an ulcer in that leg, and the study is powered to detect a 1/3 reduction over 2 years in the post-thrombotic syndrome. We're also looking at the severity of post-thrombotic syndrome using a number of different measures that I won't go into here. We're looking at quality of life using validated measures of quality of life. One of them is a venous disease-specific measure, the VANES QOL. The other one is a general measure of quality of life. We're looking at symptom relief by having patients rate their pain, their leg pain at baseline and at 10 and 30 days post-randomization using a Likert scale. And then we're also measuring leg circumferences to measure resolution of edema for patients in both treatment arms. And then finally, we're of course going to record safety in terms of bleeding complications, venous thromboembolism during the 2-year follow-up period, and deaths. And then we're also doing a formal cost-effectiveness study to look at the number of dollars per quality-adjusted life year saved, which is how quality of life is measured, cost-effectiveness is measured. And I think that this is a very well-designed study, and it's very important when you look at all kinds of research that's out there, especially in the world of image-guided procedures. The truth of the matter is that most of the stuff that we see in our literature has a lot of uncertainty that comes with the design of the studies, unfortunately. But in this study, this is a big, complicated NIH study, we actually have a number of safeguards to really make sure that the study results reflect what might be expected if we were to use these procedures in clinical practice. So we have operational separation of the PI, who's me, from the data management side. So the data gets entered by clinical centers using an online system that basically goes right into the database at the data coordinating center. I have no part in it and have no ability to influence that. When you look at co-interventions that are used during a patient's follow-up period, anticoagulant therapy, compression stockings, filters, they're handled pretty much the same in patients in both treatment arms. We have equal surveillance of patients in both treatment arms. We use central randomization, and we stratify the randomization. In other words, we allocate in approximately a balanced fashion patients with more or less extensive clot. So those with iliofemoral DVT will be balanced in the 2 treatment arms to make sure there's no bias or skewing of the cohorts. And then finally, the allocation of a patient is concealed from people during follow-up. So we try and keep the patient's medical physicians blind to whether they got lysed or not, and certainly the assessors of the patient during follow-up are kept blinded as to whether they were lysed. And then finally, the event adjudicators, in other words, the people at our data coordinating center that look at the blinded information and decide, did this count as a bleeding complication, did it not, are also blinded as to whether that information came from a patient who was lysed versus not lysed. And as a result, I think this is a very credible study, and we've gotten endorsements for a number of important organizations publicly that you can see listed in the upper right here. We have a very diverse steering committee that this is not really a bunch of interventionalists working with a company to prove that something works. This is really a very serious-minded effort on the part of both skeptics as well as proponents of lytic therapy to work together to determine, does this stuff work, and if so, in whom? And so as a result, we have a number of really national and international leaders in thrombosis research, from internal medicine, from surgery, from biostatistics, from health economics. There are DVT epidemiologists on the steering committee, et cetera, in addition to interventional radiologists. we were very fortunate to gain the public endorsement of the Office of the Surgeon General, which is, as you may imagine, a fairly unique thing. Part of the reason that occurred was that the Surgeon General issued a national call to action on DVT and pulmonary embolism in 2008, around the time the trial was starting. And in that call to action, if you read into it, if you look at the research priorities, you will note that it is listed prominently research into the benefits and risks associated with various strategies for dissolving or removing clots. And we were lucky enough to have an Assistant Surgeon General come out to our first investigator meeting in St. Louis in 2009 and provide really a compelling endorsement for the ATTRACT trial, as you can see there. On the right is our steering committee, who is, cardiologist, vascular medicine, IR, of course, IR, medical thrombosis researcher, PhD in methodology, health economist, DVT epidemiologist, interventional radiologist. So, an ER physician here, Larry Lewis here. So you could see a very diverse group here. So why in the world would the Surgeon General's office endorse a specific research study? That's not something that you ever see happening. Why this particular study? Well, I think obviously there was an interest because they were issuing their own call to action on DVT. That was obviously there. But I think beyond that, the ATTRACT trial is viewed not just as, one study evaluating perhaps one device or drug to treat a condition, but really a directional study, in the sense that since 1960, the way that we've thought about DVT is we've thought about it in terms of how do we thin the blood better? How do we prevent the next event? Really, blood thinning therapy or anticoagulation has really been the paradigm of treatment. And even now, we have new direct thrombin inhibitors coming on the market just during the last year. Even with this new change that everyone is trumpeting as being important, the reality is that that's the same paradigm we've had for something like 53 years, which is let's go ahead and prevent the next event. The problem with that is that even though we've prevented the next event pretty successfully, people get the post-thrombotic syndrome and they just don't walk the same in the long run. So I think that what's very important here is this concept of the open vein hypothesis, this idea that, does achieving an open thrombus-free vein ultimately improve a patient's outcome? If you look at the right here, we need to know which patients are best suited for this. Remember, this is an invasive procedure. Even if it works, we want to make sure that we limit it to patients that can benefit and that are at the least risk of harm. We want evidence-based care to be delivered by expert multidisciplinary teams, and the ATTRACT trial has established multidisciplinary teams of investigators at around 50 sites around the country. And our investigator teams are required to include an endovascular physician who performs the procedures, a medical thrombosis expert, an emergency room physician, and the director of the vascular ultrasound lab. So it's really a multidisciplinary approach. I think that having this network of investigators out there lays the groundwork for more pivotal DVT trials along endovascular grounds, along that sort of general line of thinking. And I think the most important thing here on the left here is that the NIH and industry need to know where do we put our dollars to achieve a health benefit in this DVT thing. Should we be investing in better ways to dissolve and remove clots and open veins, or should we be investing in something else? And there's all kinds of different imaginative directions you can take. And I think that there's a lot of thought that, well, if the ATTRACT trial is positive, the amount of investment in this whole area is going to increase dramatically. And just to give you one example, I know for a fact that there are a number of companies that actually have drugs in the pipeline that can dissolve clots without causing bleeding. And you can imagine what a powerful thing that would be to have on the market. But to put the kind of money you need to put into for that kind of investment without some type of assurance that people will actually use the therapy, I think those are investments people don't want to make yet. But if the ATTRACT trial turns out to be positive, that could change, obviously. I think also the winds are blowing in our direction. If you consider the potential pillars of preventing the post-thrombotic syndrome, preventing recurrent DVT events is one, using anticoagulant therapies, and we now have better ways to do that. We have a new class of direct thrombin inhibitors that now will enable us to put people on an anticoagulant. These are oral pills that can be given when a patient comes into the ER. No need for heparin, no need for warfarin, and no need for all the INR monitoring, which is a great thing for our patients. On the other hand, rivaroxaban, which is the only one that's FDA approved for DVT treatment at present, has the downside that there's no antidote to it. So if someone bleeds and they come in on rivaroxaban, you're kind of hosed. And again, at the end of the day, there's really no reason to believe that this would reduce the amount of clot in the vein and prevent post-thrombotic syndrome. So we wouldn't really expect a dramatic impact on PTS from a new anticoagulant. In Europe, there were 3 single-center randomized trials that suggested that elastic compression stockings used for 2 years after a DVT diagnosis reduced the risk of the post-thrombotic syndrome. And these were, and really all the treatment guidelines really have had 1A recommendations in favor of using compression stockings. Now, those were based on studies done in Europe in which people received or didn't receive elastic compression stockings along with anticoagulation. The downside of that is that people obviously knew what they were getting and that these were open-label studies. They did not have a control for the placebo effect. Most recently in North America, something called the SOX trial was just completed, and this was a much, much larger study. Again, it was double-blind, and it was placebo-controlled. So patients got either a stocking with pressure or a placebo stocking, in other words, a stocking with no actual pressure to eliminate the placebo effect. And in this study, people were followed for 2 years again, and it showed absolutely no difference in the rates of post-thrombotic syndrome, whether or not a patient wore the stocking. So this whole idea that putting a stocking on the leg can somehow repair the damage in the leg and prevent post-thrombotic syndrome is largely debunked, I think, by this study. So compression stockings are not really likely to be the way. On the other hand, the one thing we do have is that last year the COVENT trial, again, as I pointed out earlier, did suggest that removing clot prevents post-thrombotic syndrome. So I think that the evidence is pointing in the direction that, well, we need something. Compression stockings aren't going to do it, and new anticoagulation drugs probably won't, but maybe endovascular clot removal will. I'll show you a case here of a patient who already has post-thrombotic syndrome. This is a 45-year-old man with severe pain and swelling of the right thigh and calf since a right leg DVT a year ago. His symptoms have increased over the last 6 months, and he can't walk without pain, and he's now disabled from work. And this is very typical for the patients that I see in my clinic. The truth is that I treat many more patients who've already got post-thrombotic syndrome than I do patients with acute DVT, believe it or not. And we ultrasounded him, and we found a small, non-compressible common femoral vein, so a chronically occluded common femoral vein, and popliteal vein with brightly echogenic material, obviously old clot in the veins there, and no reflux. We brought him in for a venogram. We diagnosed him basically as having chronic iliofemoral DVT with no evidence of acute thrombus. We accessed his right internal jugular vein under ultrasound guidance. We brought catheters down to his right iliac vein and with some effort managed to plow ourselves through the occluded right iliac vein and managed to find ourselves into this large, deep femoral vein you see on the left here, the profunda here, that looks like a pretty nice vein of decent caliber, maybe 10 millimeters here. This little stump here that I'm pointing at is the femoral vein, which is really just a stump of a chronically occluded femoral vein. There's no real common femoral vein in here. You can see it's just a mush of collaterals here. And we also selected out the right great saphenous vein, which turns out to be kind of messed up. This narrow area at the top here, it's a very stenotic vein and not likely to be a good inflow source. So we concluded that the deep femoral vein was a good inflow source, and we went ahead and put stents in this chronically occluded right common femoral and iliac vein and opened it wide up. And here's the final venogram. You can see us injecting the deep femoral vein. The right iliac vein is widely patent here into the IVC at the top here. And this patient dramatically improved. And I'll tell you that this is literally, this is the most satisfying thing I do in my clinical practice is you take people who have not been able to walk without pain for literally years, and you open up these chronically occluded veins, and they feel great. And again, this is not thrombolytic therapy. This is just chronic occlusion therapy of stenting them open, basically. Here's another patient with, a 37-year-old man who had a motor vehicle accident a few years ago, had bilateral DVT. At the time, he couldn't be anticoagulated because of his trauma, and he had an IVC filter placed. He developed a recurrent DVT episode about 4 months ago, developed severe bilateral leg swelling. He was put back on anticoagulation, which improved it a little bit, but he continued to have bilateral aching in his buttock and thighs and edema. in his legs that were pretty significant. He also had the development of large varicosities along his thighs and lower body wall. And this was a pretty tough guy, actually, but he just couldn't get through his life like this, and he was 37 and really had to limit his activity tremendously, which is a terrible thing, as you can imagine, for someone that age. So we went ahead and accessed him. We went into his right common femoral vein, I think it was here, and as you can see, this is his right iliac, which is basically chronically occluded. You just see collaterals when you inject it. Here is all you see when you inject his IVC, just basically a bunch of collaterals in his retroperitoneum. You can see the top of an IVC filter in the non-opacifying IVC, and then you can see drainage into what's probably a hemiazygous vein over here. Here's the left iliac vein here. Again, small, chronically occluded at the top here. So basically, this is a complex iliocaval occlusion. And we tried to fight our way through the occlusion, and we couldn't get all the way through from either the bottom or the top, despite a few hours of trying with catheters and wires. Finally, what we were able to do is from the top, we were able to get a wire through the IVC filter here and into this circumaortic renal vein. And from the bottom, we were able to fight our way up and also get into that circumaortic renal vein. So what we did is we just literally put a wire out into it and snared that wire, as you can see here on the left, and we pulled it through, and then ultimately used that to get a through-and-through wire, ballooned up, and then stented right through the filter, and with wall stents. And in the end, you can see he's got a widely patent IVC and bilateral iliac veins. And his symptoms dramatically improved. And this guy actually now, he walks and he pretty much does anything like any other person. He runs, he jogs, he does everything really. And you can imagine he would have had a very difficult life, unfortunately, without this. So this is a tremendously satisfying thing. And when I think about the opportunity associated with the ATTRACT trial, we're thinking in terms of acute DVT, but I think that by showing people that you can open up veins and that opening them up makes patients better, there are zillions of patients out there that are living with these conditions that we can possibly help. So it's a tremendous opportunity. And what I found amusing actually is about a year ago, there was a consult note that came through to us. And this was actually a primary care physician and one of our vascular surgeons responding to him. And he was just referring a patient to him with bad DVT. And what he wrote back to him was that, well, treatment for DVT is anticoagulate, compression stockings, and if he's disabled, refer him to interventional radiology. And I think part of that is a recognition that we can help these people. Part of it is also maybe a recognition that some of these procedures are very technically demanding. And we have surgical colleagues that rightfully are treating these diseases as well. But honestly, when it comes to recanalizing chronic occlusions and things like that, I think that the technical skills that we bring as IRs, provided we learn the clinical medicine and we practice clinical medicine, our technical skills are second to none. And there's just so many things we can do. We actually studied our data, we evaluated our data here at Mallinckrodt in doing these procedures over a period of years. We've done it actually rather quietly. We haven't gone and made a big deal about what we're doing, but people have heard about it, I think, more and more. And what we found overall is that even with people with established post-thrombotic syndrome of moderate to severe severity, in about 80% of them, we can actually improve them significantly in terms of their symptoms, either their pain or their swelling, and also help their ulcers heal. And that's just tremendously impactful. However, we have to remember that this is us evaluating our own results. It's retrospective. It's small numbers. In no way is it blinded or unbiased. We really don't have good prospective studies showing that this stuff works, and we need some of you to come along and hopefully develop these studies along with maybe established investigators like myself, I guess. But there's just such a huge opportunity here. If you look at other areas, IVC filters, we have these neat devices that help prevent pulmonary embolism, but they also may have the problem that in the long run, they may or may not increase the risk of recurrent DVT episodes. So trying to figure out what's the right way to, who should get filters, who shouldn't get filters. It's a tremendous opportunity there that I hope that we will claim. As things stand now, we largely kind of join in with industry-driven registries that have very minimal goals. Prove the device doesn't migrate, prove the device doesn't break. But what we really need are some prospective outcome studies looking at large populations of patients and seeing, in whom are we doing good by putting a filter in and in whom are we ultimately resulting in harm. Similarly, with acute pulmonary embolism, there's a lot of excitement about the idea that catheter-directed lytic therapy and pharmacomechanical lytic therapy can dissolve clots in people with massive or submassive pulmonary embolism. This could possibly save lives in a very public and visible way. I think it's very exciting for interventional radiology. On the other hand, again, this is one where we need to prove that we're up to the research challenge here. And, to date, we're at the point where we're out promoting this idea again, but remember that these are risky therapies. A significant number of people with PE who get lysed do develop serious bleeding complications. So again, we need a lot of people to get together, and we need IRs to step up to the plate and do what our cardiology and oncology colleagues do all the time, is conduct those ambitious randomized trials and prove that these things work. I think that you're going to hear a lot of things about, you're going to hear a lot of excitement from your interventional radiology colleagues about the procedures that we do. I think that you want to thrive on that excitement. On the other hand, I think that you really need to look at things very skeptically. To give you the best example, in the 1980s, thrombolytic therapy was used for people with acute myocardial infarction and saved people's lives, and that engendered tremendous excitement. And this whole idea of the open artery hypothesis was spawned for the coronary arteries. Since that time, the use of coronary stents exploded in the coronary arteries, as many of you will know. And in 2009, the NIH-sponsored COURAGE trial was performed, and it was done really because these procedures had expanded from use in acute MI to use in people with unstable angina to people with left main disease, and finally to the garden variety patient who had stable angina. And what the study showed was that if you take a look at people with stable angina, percutaneous coronary intervention doesn't help those patients compared with just general optimized medical therapy. And this occurred, and this trial came out after about 750,000 people had received stents for coronary interventions with tremendous morbidity, actually. And so I think that's very important that we don't see 750,000 people treated with whether it's PE lysis or DVT lysis before we prove that it works. I think the NIH recognizes some of the challenges involved, and at WashU we're pleased to be one of 5 centers selected for a translational research consortium in thrombosis and hemostasis. And part of that is to expand the breadth of mentorship opportunities for research trainees so that people like yourselves that might be interested in academic research can actually get trained not just by physicians of one subspecialty, but also get access to mentors of from other disciplines so that you get different perspectives and you learn a more comprehensive global way of thinking about these problems, as I was lucky to achieve really not during my training, but during subsequent mentorship opportunities with just physicians from different fields. So anyways, I'll conclude by saying that, innovation, we talk a lot about it in interventional radiology. We're very excited about it, and it's part of our lifeblood, really, of our subspecialty. But I think it demands a different kind of ambition, and we need to rethink the way that we're looking at innovation. I think that interventional radiologists need to engage themselves in their medical world of DVT care. So every hospital has a DVT prevention committee. They have quality assurance and safety committees that are committed to patient welfare. I think that even if it's not DVT that you personally get involved in as a developing IR, whether it's PAD, whether it's interventional oncology, whatever, you want to be seen as a proponent of great patient care, not as a proponent of a particular procedure. And that's how you're going to gain credibility. That's how you're going to do the right thing. And that's how you're going to broaden your perspective and learn about your disease. So very important to get involved in the general environment there and really do your part to contribute to patient care. I think we need to be ambitious. And in particular, I think that really to date, interventional radiology, for the most part, we haven't driven the research agenda. We've let companies drive the research agenda, and then we kind of pile on as part of their studies. So they develop a study, and we say, sure, we'll be part of it. Well, we need more investigators in interventional radiology, like there are in other disciplines, that are going to lead the agenda and say, well, actually the question that we want to answer is not whether your device breaks in a month. I know that'll get you on the market for the FDA, but what we want to know is, does your device help people over a 2 or 5 year period? So we need people that are going to really do that. We need you to all learn and kind of combat interventional radiology groupthink. You know, we all kind of start to develop our own pro-procedure mindsets in whatever area we're in. Well, we need to be thinking about these problems from a more comprehensive perspective. And then finally, I think the culture needs to change. You all, I think, are well aware of that. I know that your group, the RFS group, has been very active in trying to promote changes in IR culture, and I really applaud you for doing that. I think some of the things we need to do, we've got a new pathway. This new IR residency is developing. We need to integrate research training into there somehow. I think we need to get young investigators opportunities. For example, lots of the cardiology investigators I know, lots of the oncology investigators I know, they've got master's degrees in clinical investigation in addition to their MDs. We need more radiology trainees and IR trainees to go and look for those opportunities. And if they're thinking about doing clinical research in the long run, become trained as a clinical researcher. Remember, your IR training trains you to be a doctor, not necessarily a researcher. I didn't have that training, by the way. I actually evolved into my research pathway later on, but I can tell you there were a lot of bumps and bruises along the way, and I love looking back. I would love the idea and the opportunity to have actually gotten some training up front. I think we need to engage the community for our pivotal randomized trials and really promote a culture of research and clinical trials enrollment. In other words, for trials like ATTRACT and other pivotal trials, we need IRs to kind of come together and say, here are the 3 big trials that are going on. Let's make sure that as a community we get people into those trials. Because if you think about the ATTRACT trial, we've gotten 441 patients in over a 3-year period. If you think about that 3-year period, about 2 million people were diagnosed with DVT in the United States. If we say that we end up not meeting our target of 692 patients, are we going to really be happy saying that there were 2 million people with DVT and during that time period? Well, that reflects, I think, on our overall culture, and hopefully you all can play a big role in changing it. So, anyways, that's my talk. I'm sorry if I went over, and thanks a lot for your attention. I'll take any questions if anyone's still there. Hello?
Well, I guess if there aren't any questions, thank you again, Dr. Vedantham, for coming out and talking to the RFS group. We appreciate it.
Okay, great.
And everyone have a good night.
Okay, thanks a lot. Take care.
You too.
Yeah, bye.